Hello, my name is Niyati Patel, and I am a fourth-year medical student at Nova Southeastern University. Today, I will be presenting a case of pericardial effusion in the presence of severe hypothyroidism. Before I begin, I would like to give a special thank you to my colleague Amrit Reddy and to Dr. Guter for assisting me on this presentation. We begin with a 44-year-old African-American female with a past medical history of intellectual disability, multiple personality disorder, schizoaffective disorder, diabetes mellitus, hypothyroidism, congestive heart failure, and hypertension, who presents to the emergency department with the chief complaint of a worsening shortness of breath and a cough. This patient is known to reside at an inpatient psychiatric facility. Her home medications include amlodipine, atenolol, chlorthalidone, valproic acid, quidapine, trazodone, and benztropine. However, this patient's adherence to medication regimen is unknown. On admission, her vital signs reveal a high blood pressure at 158/92, a heart rate of 60 beats per minute, O2 saturation of 95% on room air, respiratory rate of 20, and a temperature of 97.5 degrees Fahrenheit. In the emergency room, it was noted that the patient had a constant non-productive cough. On physical exam, her pulmonary exam showed decreased breath sounds with crackles at the lung bases and bronchi in the central airways. Her cardiovascular exam showed muffled S1 and S2 with no S3, S4, or murmurs. Her psychiatric exam revealed delirious speech and disorganized thoughts. However, because the patient has had multiple admissions in the hospital in the past, this was noted to be her baseline. Her labs reveal a CBC, which showed iron deficiency anemia. Her CMP revealed no acute findings. Her inflammatory markers were within normal limits. However, her TSH was elevated at 97.1, with her T3 and T4 levels being low. In the emergency room, an EKG was ordered, and that revealed pulsus alterans. A chest X-ray revealed an enlarged cardiac silhouette with interstitial markings. Because of the abnormalities noted on the chest X-ray, a CT scan was ordered, and that revealed an enlarged pericardial effusion. Because of the abnormalities in the EKG and CT scan of the chest, an echocardiogram was ordered, and that revealed an ejection fraction of 60% and a large pericardial effusion. The patient's CT scan of her head and brain was negative. Because of her past medical history of congestive heart failure, the patient was started on furosemide in the emergency room. Cardiology, CT surgery, and endocrinology were all consulted. CT surgery recommended against doing a pericardiocentesis or a pericardial window because of this patient's hypothyroidism. They suggested, however, that this is most likely the etiology, and so the patient was started on IV levothyroxine. This patient's symptoms improved, and she was then discharged on oral levothyroxine. Hypothyroidism is known to cause pericardial effusion because it leads to an increased permeability of pericardial capillaries, leading to a loss of albumin to the pericardial space, as well as decreased excretion of albumin into the lymphatic system. This results in a total increase in oncotic pressure in the pericardium, which further draws fluid into the pericardial space. This patient's hypothyroidism could have been due to the lack of levothyroxine included in her routine medications, or because of a side effect of her psychiatric medications, which are known to rarely induce hypothyroidism. Rather than performing an invasive procedure on this patient and increasing her risk of infections and increasing the risk of her dislodging the piglet drain, medical management helped to alleviate this patient's symptoms. This case is really important because it shows us that hypothyroidism-induced pericardial effusion is an important differential to consider in patients who are showing symptoms of hypothyroidism or who have a known history of hypothyroidism. By keeping this in mind, we can ensure that patients do not undergo an invasive procedure when it is not necessary. Thank you.